Mucocutaneous lymph node syndrome (MLYS). Kawasaki disease. Mucocutaneous lymph node syndrome (MLYS). Introduction: the leading cause of acquired heart disease in children. Kawasaki disease, KD, is a common vasculitic disorder usually seen in children below 5 years of age. The leading cause of acquired heart disease in children. Kawasaki T. Acute febrile mucocutaneous syndrome with lymphoid involvement with a specific desquamation of the fingers and toes in children. Clinical observations of 50 cases. Japan J. Alajol. 1967, 16, 178-222, China. Kawasaki disease. Epidemiologic study of admitted children with Kawasaki disease in Beijing from 1995 to 1999. The incidence of KD in Beijing is lower than that reported in Japan, similar to the incidence in the United States and higher than in those other Western countries. Etiology: no one knows what causes Kawasaki disease, but it is thought to start from an infection or from exposure to some toxin. There is no firm evidence that the disease can spread from one person to another. Superantigen-producing bacteria. History: Kawasaki disease has 3 stages, as follows: acute stage, 1 to 11D. Subacute stage, 11 to 30D. Convalescent/chronic phase, greater than 30D. Acute stage, 1 to 11D, 1. High fever, temperature greater than 39°C. 2. Non-exudative bilateral conjunctivitis, 90%. 3. Polymorphous erythematous rash. 4. Acral erythema and edema that impede ambulation. 5. Strawberry tongue and lip fissures. 6. Lymphadenopathy, 75%, generally a single, enlarged, non-suppurative cervical node measuring approximately 1.5 centimeters. Acute stage. Non-exudative bilateral conjunctivitis, 90%. Acute stage. Polymorphous erythematous rash. Acute stage. Acral erythema and edema that impede ambulation. Acute stage. Strawberry tongue and lip fissures. Acute stage. Lymphadenopathy, 75%, generally a single, enlarged, non-suppurative cervical node measuring approximately 1.5 centimeters. Acute stage, 1 to 11D. 7. Hepatic, renal, and gastrointestinal dysfunction. 8. Myocarditis and pericarditis. 9. Irritability. 10. Anterior uveitis, 70%. 11. Perianal erythema, 70%. Irritability. Subacute stage, 11 to 30D. Persistent irritability, anorexia, and conjunctival injection. Decreased temperature. Thrombocytosis. Acral desquamation. Aneurysm forms. Aneurysm forms. Convalescent/chronic phase, greater than 30D. Expansion of aneurysm. Possible ME. A tendency for smaller aneurysms to resolve on their own, 60% of cases. Diagnostic criteria. 1. Fever greater than 5 days, and refractory to appropriate antibiotic therapy. 2. Polymorphous erythematous rash. 3. Oropharyngeal changes, including diffuse hyperemia, strawberry tongue, and lip changes, e.g., swelling, fissuring, erythema, bleeding. Diagnostic criteria. 4. Peripheral extremity changes, including erythema, edema, induration, and desquamation. 5. Non-purulent cervical lymphadenopathy. 6. Non-exudative bilateral conjunctivitis. Diagnostic criteria. Patients with classic Kawasaki disease must have 5 of the former symptoms, with fever an absolute criterion. Differentials: staphylococcal infection, such as scalded skin syndrome, toxic shock syndrome. Streptococcal infection, such as scarlet fever, toxic shock-like syndrome. Throat carriage of group A Streptococcus does not exclude the possibility of Kawasaki disease. Differentials: measles and other viral exanthems. Leptospirosis, rickettsial disease, Stevens-Johnson syndrome. Drug reaction: juvenile rheumatoid arthritis. Lab studies: mild to moderate normochromic anemia, moderate to high WBC count, ESR, C-reactive protein, and serum A1 antitrypsin. Culture results are all negative. Lab studies: ANA, RF, azonormal platelets, thrombocytosis, 23W, associated with severe coronary artery disease and ME. Liver enzymes: AST, ALT, bilirubin. Lab studies: cardiac enzymes, CK, CKMB, cardiac troponin, LDH. Radiography: rule out cardiomegaly or subclinical pneumonitis. Imaging studies: echocardiography: rule out SARS and the myocarditis, valvulitis, or pericardial effusion. Diffuse dilatation of coronary lumina can be observed in 50% of patients by the 10th day of illness. Echocardiography should be repeated in the 2nd or 3rd week of illness and 1 month after all other laboratory results have normalized. Imaging studies: ultrasonography, gallbladder ultrasonography, liver or gallbladder dysfunction. Scrotal ultrasound to evaluate for epididymitis. Imaging studies: MRA, defines SAR in patients with Kawasaki disease. Non-invasive, other tests: ECG, acute infarction, tachycardia. A prolonged PR interval. St. T wave changes. Decreased voltage of R waves may indicate myocarditis. Q waves or St. T wave changes may indicate ME. Medical care. The main goal of treatment is to prevent coronary artery disease and relieve symptoms. Full doses of salicylates, aspirin, intravenous gamma globulin are the mainstays of treatment. Drug category: EVIG, first line but not the sole therapy. Neutralizes circulating myelin antibodies through anti-idiotypic antibodies. Downregulates pro-inflammatory cytokines. Blocks Fc receptors on macrophages. Suppresses inducer T and B cells and augments suppressor T cells. Blocks complement cascade. Promotes remyelination. EVIG 400 mg/kg/D4 as a single daily infusion for 4D5D. Alternatively, 2 g/kg4 infused over 12 hours once a single dose. Drug category: aspirin, decrease inflammation. Inhibit platelet aggregation. Improve complications of venous stasis and thrombosis. Irreversibly inactivates cyclooxygenase, ultimately preventing thromboxane A2 production in platelets. Drug category: aspirin 80 to 100 mg/kg/depot divided KD for 2 weeks initially, then 5 to 10 mg/kg per QD for 6 to 8 weeks until sedimentation rate and platelet count are within the reference range, typically used for 6 to 12 weeks. Drug category: corticosteroid. Not recommended to use only. Prescribed only when the therapeutic effect of EVIG is not satisfied. 2 mg/kg, 2-4 weeks. Complications: cardiovascular. Significant heart failure or myocardial dysfunction, unlikely to occur once fever is resolved. Diffuse coronary artery ectasia and aneurysm formation, giant aneurysm, internal luminal diameter greater than 8 mm. ME. Complications: cardiovascular. Myocarditis, common but rarely causes CHF. Valvulitis, usually mitral, only occurs in 1% of patients and rarely requires valve replacement. Pericarditis with small pericardial effusions occurs in 25% of patients with acute illness. Systemic artery aneurysms. Rupture of cell with hemopericardium, other complications. Extreme irritability, especially in younger infants. Aseptic meningitis. Arthritis. Mild hepatic dysfunction, rarely jaundice. Other complications. Gallbladder hydrops, diagnosed by means of ultrasonography but usually resolves without surgical intervention. Diarrhea. Pneumonitis. Otitis media, other complications. Erythema and induration at the site of BCG inoculation, reported in Japan. Peripheral extremity gangrene, extremely rare. Bowel ischemia and necrosis, prognosis. With prompt treatment, the prognosis is good. The current mortality rate is 0.1 to 2%. 2% to 4% of treated children still develop coronary artery disease.